Welcome back. In today's Explainer, we are jumping right into part 10 of our CPC exam series. We're tackling the digestive or gastrointestinal system. And let me tell you, GI coding can be incredibly tricky. Why? Because it is heavily, and I mean heavily, location dependent. Literally, a single segment change in the documentation will completely change your code. So before we dive in, make sure to like, share, and subscribe to Decode Healthcare with Harshal, and let's master this together. Here is our quick agenda for today. We'll map out the GI pathway, check out the accessory organs, lay down the endoscopy scope rules, flag some major coding pitfalls, and wrap it all up with a summary.
Starting off with Section 1, the GI pathway explained, navigating the map.
All right, to code the GI system accurately, you've really got to visualize it as a giant geographical map. And it's a big one, stretching roughly 30 feet in an adult. We start at the top and move sequentially down. The upper and mid-GI kicks off at the oral cavity, goes down the esophagus, into the stomach, and through the small intestine, which breaks down into the duodenum, jejunum, and ileum. Then we hit the lower GI, the large intestine or colon, spanning from the cecum through the sigmoid and finally ending at the rectum and the anus. You've got to know these exact segments because different anatomical terms map to completely different code categories. Coding a lesion in the duodenum is vastly different from coding one in the cecum for sure. Moving right along to Section 2, accessory organs and pathologies. Think of these as the potholes on our road. Okay, so now that we know the main highway, let's look at the accessory organs. Notice how these high-yield pathologies align perfectly with specific organs. For the liver, you're looking out for hepatitis and cirrhosis. Gallbladder, that's cholelithiasis, or gallstones. Then you have the pancreas. Up in the upper GI tract, you'll frequently code gastritis, GERD, and peptic ulcers. But you really need to pay close attention to the lower GI, specifically inflammatory bowel disease. A major exam trap is missing the difference between diverticulosis and diverticulitis. Literally one tiny suffix change from osis, meaning an abnormal condition, to itis, meaning inflammation, drives you to a completely different diagnosis code on test day.
Next up is Section 3, endoscopy scope extent rules. The vehicles of the GI tract.
So we know the map, but how do we actually travel it? We use procedures, specifically endoscopies. Compare these two vehicles, keeping this absolute golden rule in mind. How far the scope travels defines your code category. Take an esophagogastroduodenoscopy, or EGD. It's an upper GI scope. The name tells you exactly how far it goes. Esophagus, stomach, duodenum. On the flip side, a colonoscopy enters from the bottom, traveling through the rectum all the way up to the cecum, or sometimes just the splenic flexure. You always choose the code based on the most definitive service performed and the furthest distance that scope actually traveled.
The crucial point here is that your approach and extent dictate everything. Beyond endoscopies, you've got to watch for these high-yield interventions. Take cholecystectomies. You must distinguish between a laparoscopic versus an open approach because they belong to entirely different CPT code families. Then there are colectomies. Is it a partial or total bowel resection? Was an anastomosis created? Are you coding a polypectomy or a biopsy? The tiny details in that operative note hold the key.
Let's move into Section 4, GI coding pitfalls. These are your speed traps and confusion alerts. Let's check our blind spots for those high-yield exam speed traps that can completely ruin your coding accuracy. A major trap, confusing distinct terminal endpoints. Guys, the rectum is not the anus. They are totally distinct anatomical endpoints with different codes. Similarly, you cannot just code unspecified colon if the operative note explicitly says ascending or sigmoid colon. You've always got to drill down to the exact sublocation. And that brings us to the infamous modifier 59, or the XS modifier for separate structures. You know the National Correcting Coding Initiative, or NCCI, often bundles procedures together. Well, to bypass those edits and legitimately bill for multiple procedures, you absolutely must have a truly distinct anatomical site or separate lesion during the exact same encounter. Imagine this scenario. It brilliantly illustrates the rule in action. A gastroenterologist performs a colonoscopy. They remove a polyp using a snare technique in the ascending colon. But during that same session, they biopsy a completely separate lesion over in the sigmoid colon. Because these are distinct lesions in completely separate anatomical segments of the colon, you report 45385 for the snare polypectomy, and then you append modifier 59 to the biopsy code 45380 to prove it was a distinct service.
Finally, Section 5, Summary and Part 11 Teaser. We have reached the destination.
Let's lock in these high-yield coding concepts real quick. First, always map the exact GI segment. Do not settle for unspecified. Second, for endoscopies, code strictly by scope travel distance. Third, remember that a laparoscopic versus an open approach changes the entire code family. And fourth, use modifier 59 or excess only when the documentation definitively proves distinct lesions or separate anatomical sites.
Coming up next, in Part 11, we are tackling the genitourinary system. We'll be breaking down the upper versus lower tract, the kidneys, reproductive anatomy, and UTI locations. Until then, I'll leave you with this provocative thought. When coding an infection, why does confusing cystitis in the lower tract with pyelonephritis in the upper tract trigger entirely different reimbursement pathways? Think about it, and we'll answer it next time. Thanks for checking out this explainer, and keep decoding.